Welcome back to SurgiSmart Cut to the Core. All right, today we're going to dive deep into the intricate mechanics of swallowing and, what happens when that whole system just goes haywire. Okay, let's kick things off with a number that really paints a picture. 22%. That's how many adults over 50 are dealing with dysphagia. That's the medical term for difficulty swallowing. It's a super common complaint, but it can be a red flag for some really serious issues going on in the esophagus. So, to really get what goes wrong, you first got to appreciate how elegant the system is when it's working right. I mean, peristalsis, it's this amazing, coordinated, wave-like contraction that pushes food down the esophagus. Think of it as this perfectly synchronized dance. And this is where the magic happens. It's really a three-step process. First, the gate at the top, the UES, it relaxes. Then, that peristaltic wave starts its journey down. And finally, the gate at the bottom, the LES, opens up right on cue to let food into the stomach. Now, if any part of that sequence gets messed up, say a gate won't open or the wave is just weak or totally chaotic, the whole system just grinds to a halt. All right, so let's dig into the different ways this elegant system can actually break down. We have a way of classifying these disorders, which really helps us figure out the cause and, what to do next. So the first big split, the first major fork in the road, is figuring out if the problem is just in the esophagus itself, that's a primary disorder, or if the esophageal issue is just one piece of a bigger puzzle, part of a systemic disease like scleroderma. That's a secondary disorder. And making that distinction, absolutely critical for diagnosis and treatment.
And this table, it lays out the whole landscape for us, just brilliantly. You can see how we can break it down even further. Are we dealing with a problem of movement, the neuromuscular stuff, or is it more of a plumbing issue, like a physical blockage? And right there, you can see where a classic disorder like achalasia fits in. It's a primary motility problem.
Okay, let's zoom in on achalasia. It's really the poster child for these motor disorders because it's so well defined. Here's the core of the problem. The nerve cells inside the esophageal wall, they get destroyed. And when those nerves go, two things happen. The lower sphincter can't relax, and that peristaltic wave just dies out. It's basically a communication breakdown. So imagine a patient walks in, they're having trouble swallowing. How do we crack the case? How do we figure out if it's achalasia or something else entirely? Well, the diagnostic workup is a really systematic process. It's all about elimination and confirmation. And you know what? It all kicks off with one simple but incredibly powerful question. Seriously, the patient's history is everything. Their answer pretty much sends us down one of two paths right away. This is it. If the patient tells you they're having trouble with both solids and liquids from the get-go, your brain should immediately be thinking motility disorder. It's like the pipe is clear, but the pump is broken. On the other hand, if they say they had trouble with solids first and then it progressed to liquids, that points more toward a mechanical blockage. The pipe itself is getting narrower. Okay, so after we've got the history, we often move on to imaging. A barium swallow can give us these classic, almost iconic visual clues. For achalasia, you get this bird's beak look. The esophagus narrows down to this super fine point right at the LES. I mean, it looks exactly like its name. It's a huge clue. But look, to really, truly confirm what's going on, to understand the nitty-gritty of why it's failing, we have to measure the pressures inside the esophagus. And that's where we cut to the core of the diagnosis. The gold standard test, high-resolution manometry. Manometry gives us the cold, hard data. We're looking at things like the IRP. That tells us if the lower sphincter is actually relaxing. Spoiler, in achalasia, it isn't. We check the distal latency, which is all about the timing of that wave. And then there's the DCI. That's the raw power, the shear force of the squeeze. These numbers aren't subjective. They objectively define the disorder for us. And speaking of the DCI, this is where things can get pretty wild. There's this condition called jackhammer esophagus, and the name says it all. The contractions are just unbelievably powerful. We're talking a DCI over 8,000. There's simply no way to diagnose this kind of extreme hypercontractility without manometry. Okay, so we've used manometry, we've nailed the diagnosis. Now what? Well, now we turn to the management playbook, and it's all about relieving those symptoms and really just giving the patient their quality of life back. We've basically got two main avenues to go down. For earlier or milder cases, we can start with medical therapy. Try to get those muscles to chill out with some drugs. But if the disease is more severe or it's just not responding, we have to get more hands-on. We have to physically go in and release that high pressure at the junction. So what's in our pharmacological toolbox? Well, we've got the classic smooth muscle relaxants like nitrates and calcium channel blockers.
But it's not just about that. A lot of these patients have related issues, right? So we might use PPIs for the acid reflux that often comes along for the ride, and even low-dose antidepressants. And that's not for depression per se. They can actually help modulate the nerve signals that are causing all that pain. Now, when we move to interventions, it's like climbing a ladder of invasiveness. We can start by just stretching the sphincter with a balloon. Or, for patients who aren't great surgical candidates, we can temporarily paralyze it with a little botulinum toxin. The big gun, the definitive surgical fix, is a Heller's myotomy, where a surgeon literally cuts the muscle. And in the absolute worst case, end-stage scenarios, the only option left is to remove the esophagus entirely. All right, let's finish up with some really high-yield clinical pearls. These are the things that are super critical to remember in your day-to-day practice. And we'll start with a classic diagnostic trap.
This one is all about timing. A patient comes in saying they have a lump in their throat. The most important question you can ask is, when do you feel it? If they feel it during a swallow, as food is trying to go down, that's real dysphagia. But if it's this constant sensation that's there between swallows, that's something else entirely called globus sensation. And it's often tied more to things like anxiety. So what's the long-term outlook? Well, it really depends on what you're dealing with. The spastic disorders, generally, the prognosis is pretty favorable. Scleroderma, it's all tied to how the main disease progresses. But achalasia, that's a different beast. It's chronic. It's progressive. Our treatments are about managing symptoms. They're not a cure. And these patients will likely need more procedures down the road. And that brings us right back to where we started and why all of this matters so much. 45%. Think about that number. That is the one-year mortality rate for residents in a nursing home who have dysphagia that leads to aspiration. The stakes here are just incredibly high. I mean, a number like that, it's staggering. And it really forces us to ask ourselves, how can we be better? How can we speed up our diagnoses? How can we be more accurate? How can we intervene more effectively to stop the devastating consequences of these disorders? That's the challenge for all of us.